And welcome back, ladies and gentlemen. We are having a great day. I want to stress to you there's more to be accomplished here than saving a person from diabetes or from heart disease or causing weight loss. We have a world to save for our future, and we need all of us working together. And along the way, I have a chance to meet new friends, new people who are bringing strength and force to what we need to accomplish. And I had that great opportunity last week in Houston, Texas, to meet a man who's going to help us change the world. A cardiologist. Oh, no, a cardiologist. And an interventional cardiologist. That means he sticks things into people. Yes, but he has, well, I'll let him tell you his own story, but he's a powerful man. I can't think of somebody who I've been more impressed by than our next guest, Dr. Baxter Montgomery.
Thank you, sir. Thank you. Thank you very much. Thanks, Dr. McDougall. Can you hear me okay? Good. What I want to share with you is our approach to medicine in Houston. And I'd like to think of this approach as a model for the future. It's called the Food Prescription for Better Health. And it's a novel. Notice novels in quotation marks. There's some aspects of what we do that's not so novel. But it's a novel healthcare delivery model that I think is going to help us out in the future. Now, as Dr. McDougall pointed out, my day job is as a cardiologist. I'm assistant professor at the University of Texas Health Science Center at Houston. And I practice in the world's largest medical center. And in the daytime, I'm prescribing medications, doing procedures, et cetera. Perhaps being the bad guy in this arena. But my night job is to help people avoid my day services. And I work as director. Thank you. I work as director of Montgomery Heart and Wellness and the JAM Institute. It's our health and wellness center, and we use wellness interventions, and I'm going to go through the details of that in my talk. This slide gives you a little bit of perspective. This picture in the upper left, excuse my pointer, is a Texas Medical Center. And this is an old picture. There are many more buildings in the Texas Medical Center. This is the world's largest medical center. Just to give you some perspective, there are 3 heart transplant centers right here in this medical center within walking distance. 3 major facilities. They do everything advanced in terms of in the form of cardiology, neurology, neurosurgery, and the like. It has a trauma center. We can life flight patients from anywhere in the country. So it's a very powerful healthcare facility, conglomerate. Right here, this little building is about 4 miles south of this area here. We're in the shadows of the medical center, and this is where I hang out most of the time. I work here in one of the hospitals, and I do most of my work here, mostly in the day and at nighttime. And this is Houston Cardiac Association, but this is where the Montgomery Heart and Wellness and the JAM Institute is housed. And we're going to talk about our approach to medicine and how we do this. Now, this is a busy slide. It's going to give you the outline of what I'm going to cover for the next 2 to 3 hours in the next 300 slides that I have. Dr. McDougall said I had some extra time. We're running early, so I figured I'd add a few extra slides. Just kidding. So the first few bullet points, why is this approach urgently needed? I'm going to talk a little bit about the epidemiology of chronic illnesses, the underlying cause of healthcare problems, some cost issues. Then I'm going to talk about this whole current aspect of our approach to this problem. And I'm going to cover this in a little scenario, Jim and a sore thumb. I'm going to get into some scientific basis for the nutritional interventions, talk a little bit about the biochemistry and physiology, but I'm sure that Dr. Campbell has covered a lot of this. I'm not going to spend too much time on this. Most of my time will be spent on this latter part. We're going to start with the food prescriptive approach to integrate it in a clinical setting. We're going to talk about exactly how you take these concepts and principles of plant-based nutrition and how do you practice this, apply this, I should say, on a day-to-day basis. What do I do when someone walks into my office and they say, hey, I'm having chest pain or shortness of breath? Or what do I do when someone comes to the emergency room and I have to admit them to the hospital? How do I apply nutrition in both of those settings? And we're going to talk about that. We're going to talk about it from a conceptual aspect. So what are the concepts that we deal with? Then we'll go over a hypothetical model, a program model. I'm going to talk about the quote-unquote institutions that we have to create, the critical personnel that we've developed, the facility side itself, and the details of the programs. And then I'm going to go into the detailed aspects of the food prescription. How do we assess patients? How do we optimize medical and surgical intervention? And how do we apply this food prescription that I talk about? And not so last, but almost last and not so least, we're going to talk about some examples, and we're going to talk about, show you some of the data that we have, and we'll open the floor to questions. So why do we need this approach? This slide I use a lot in my talks. It talks about how heart disease doesn't discriminate. You have a series of bar graphs, and this looks at the prevalence of heart disease as we get older. And you look at the age groups 20 to 34, 35 to 44, 45 to 54 and older, the prevalence of heart disease increases. That's one aspect. The other thing is that you notice that the bar graph on the left is for men and on the right is for women. Sorry that they're so close in color. Notice how in the younger age groups, women have less heart disease than men. And as we get older, around the age of 45 to 50, women catch up and they pass men up. And in fact, more women die of heart disease or suffer and die from heart disease than men. Heart disease is now a woman's disease. But perhaps one of the most important things that this slide shows is what it doesn't actually show. If you look at this age group, the 20 to 34-year-old age group, and you look at the men, it estimates that the prevalence of heart disease in men is about 11.2%. However, back in the early 50s, they did an autopsy study on male soldiers who died from traumatic injuries in the Korean War. And they examined about 300 hearts. And they didn't find an incidence of 11%, but what they found is almost 80%, around 77% of these men had gross plaque in their coronary arteries. That's nearly 8 out of 10, and the average age was 22. Subsequent autopsy studies have confirmed this. So if you look at the disease state in the men, average age 22, who were exercising regularly, by the way, they were fit soldiers, they had gross coronary artery disease. So if you take the tail of this arrow and don't start it here, but start it actually at 80%, and then you project it up, you can only imagine that the prevalence of heart disease is virtually universal beyond the age of 30, 40 years old. So heart disease doesn't discriminate. Let's look at other disease. Let's look at hypertension. Hypertension, as we get older, same story. It gets more progressive, more prevalent in the older age groups. Women, less hypertension in the younger ages, pass men up. Similar story. If you look at diabetes, we look at a population survey from 1980 to 2010, we've had a rampant increase in the prevalence of diabetes in our population. Not only has more people, a higher percentage of our individuals have diabetes, but younger and younger individuals are getting diabetes. It's nothing for an 8-year-old, 10-year-old, 13-year-old to have type 2 diabetes. When I was in medical school, this was virtually unheard of. And so we're getting sicker and sicker over time. Kidney failure, again, the prevalence going up over time, projected to be over 600,000 in year 2015. So you could just about put any disease state in these graphs and pretty much show the same trajectory. So what's the cause of this? I don't really have to go through this in detail, but we'll have a few slides on this. From the early 1900s to early 2000, we've been eating more meat. Now, most patients come to my office and say, well, doctor, I've cut back on my meat. And code term meat is red meat. And if you look at it, they're right. They have cut back on their red meat. However, they've increased their chicken. This is the impact of the Chick-fil-A commercials. Notice the exponential growth of the chicken consumption over time. Look at the cheese consumption over time from the early 1900s to almost a 10-fold increase. And the sugar, the total amount of sugar, this top bar graph, the red, shows the increase in total amount of sugar. However, it's paralleled by the processed sugar. This is the high fructose corn syrup here. The natural sugars from canes and beets have gone down. So we're eating more processed sugars in our foods. So again, in short, what's the problem? The problem is we got too much of the wrong Mickey D. It's in the food. And so we're going to show you how, in the clinical practice, we try to remove the food, the poisonous food, and replace it with nutritious food. It's important. This is a slide I put together. We looked at the top 10 countries by gross domestic product. And this slide is actually about 6 or 7 years old. These numbers may have changed to some extent. But the point is, if you were to take the amount of money that the U.S. spend on health care, or should I say sick care, we'd be the 6th richest country. It would be enough money for the 6th richest country in the world. More than the total gross domestic product of the United Kingdom, Italy, Brazil, pretty prominent countries. So we're spending a lot of money on sick care. But as those previous graphs I showed you, we're not getting very much for the money we're spending. So a paradigm shift is needed. Healthcare costs continue to rise. It impacts us individually as well as in businesses. There are many advances in medical and surgical therapies. You know, in the medical center now, we can replace your aortic valve without opening your chest. We can do a lot of things percutaneously. You know, aortic stenosis patients used to have their chest open. Now we can do it with catheters. So many advances in medical therapy. We can ablate ventricular tachycardias and ablate atrial fibrillation. However, all of these advanced therapies do not really reach the masses of individuals with heart disease. And chronic diseases are essentially foodborne illnesses. Genetics play a very small role. The Western diet is a chronic denominator. So what are we doing about this? You know, we're in Houston, the largest medical center in the world, and we have all of this illness. What does the typical doctor do when a patient walks in their office? Well, let's ask Jim. Jim comes into his doctor with a sore thumb. Now, he got a vice grip stuck on his thumb. For those who are not mechanically inclined, this is a vice grip. About 2 weeks ago. So 2 weeks ago, working in his garage, gets a vice grip clamped on his thumb, gets stuck there, his thumb gets sore, swollen. He comes in, pain on the right thumb for 2 weeks. He sees his family physician. The doctor says, well, you know, he takes a history, examines him, family history, no history, family history of thumb problems. Examines the right thumb is swollen, tender. On exam, the left thumb is fine. The other exam is fine. So after thorough evaluation, takes out his prescription pad, prescribes 200 milligrams of Motrin every 8 hours, Tylenol number 3 every 4 hours is needed, and asks Jim to follow up in 2 weeks. So Jim walks out with his prescription in his hand, vice grip on the thumb, and on his way. So visit 2, he comes back and says, you know, I had some pain relief for the first week and a half, but it came back. It's still swollen overall. However, I'm a little constipated, doc. And so his doctor, being the astute clinician he is, increased the Motrin to 400 milligrams every 8 hours, changed the Tylenol number 4, which has 60 milligrams of codeine, but the constipation he treats with lactulose, 30 cc's every 12 hours as needed for constipation. Now, of course, he's given him NSAIDs, which can affect the kidney, and the Tylenol can affect the liver. So he gets blood tests for the kidney and liver. And it says, follow up with me in 2 weeks. So Jim walks out with new prescriptions in the hand, vice grip on the thumb, and comes back for visit 3. Now he's had partial pain relief for 2 weeks, so he's getting a little better. Although he still has some swelling, worsening constipation. However, the blood tests were a little bit concerning, abnormal kidney and liver function. So the doctor changed the NSAID to Indocin, puts him on keeps him on Tylenol number 4, but he refers him to a kidney and GI specialist for an abnormal kidney function test, say follow up in 6 weeks. However, the conclusion of Jim's saga, he rushes to the hospital because one night he's febrile, found to have an infection due to a gangrenous thumb. He undergoes a thumb amputation. His kidney fails due to infection and NSAIDs. He gets discharged from the hospital on dialysis, but his new insurance policy covers everything. No application due to pre-existing condition. So Jim leaves elated. He's marveling at the wonders of modern medicine and the power of Obamacare. So this is a fantastic story. However, you guys were laughing during the therapy. Was there something wrong? Was I missing something here? Do you guys have any alternative approaches to this? Remove the vice grip? I agree. You know, this is funny in a way, But in a way, it's not funny, because hundreds of thousands of patients walk into their physician's office day after day after day, and they have high blood pressure, headaches, chest pain, arthritis, etc., weebie-jeebies. And the doctor writes for prescription after prescription, referral after referral, therapy after therapy, but we refuse to remove the vice grip on the thumb. And the vice grip on our thumb is the standard American diet that continues to poison our system. It continues to elevate the blood pressure. So despite the fact I may give you one blood pressure medication, if I don't remove that vice from your thumb, the blood pressure will go up and I'll have to give you a second blood pressure medication, then a third, then a fourth. And the same thing with cholesterol and your arthritis. So we have to talk about how we go about removing the vice grip from the thumb. And I hope to go over that in some of the concepts that we're going to cover as we apply the food prescription for better health. Let's look at some of the scientific basis for plant-based nutrition. I said I was going to mention this only from the standpoint of giving some context. We have Dr. Campbell here. He's got several talks. You guys are probably already experts on this concept already based on what you've heard. But this is a graph that talks about the nutritional components of animal-based foods. This is actually from Dr. Campbell's book, The China Study, and a nutritional composition of plant-based foods for a given 500 calories per food. The only advantage you have from dead animal flesh is cholesterol and fat. The protein amount is virtually equal given the amount of calories, but you have much more in the way of phytonutrients and vitamins and all the other nutrients that are needed for maintaining health and rebuilding the body and developing the immune system and the like. So you have a superiority of plant-based foods. If we look at this slide, this is a little cartoon showing a cell, and it's depicting the increased amount of fat cells inside the cell. And this has been shown to be associated with the consumption of animal protein. So the increased animal protein consumptions has been shown to result in intramyocellular lipid formation, or increased fat cells deposits inside cells. It results in mitochondrial dysfunction. These are the energy organelles of the cell. And it results in inflammation, resulting in insulin resistance. And so the insulin resistance underscores the majority of causes of type 2 diabetes, or majority of causes of diabetes, that underscores type 2 diabetes, and results in progressive metabolic derangements that eventually leads to what we call diabetes. So in summary, there are a lot of clinical studies, and I haven't reviewed them, that talks about how that shows the efficacy of plant-based nutrition in reversing heart disease. There's a superiority in the nutritional composition of plant-based foods, and we know of biochemical mechanisms that underscore the derangement of our cells and tissues that lead to chronic illnesses. So there's science, strong science and evidence that supports the use of plant-based foods for improving chronic illnesses. So then how do we take this to the bedside? You know, this whole concept of bedside, Dr. Campbell talked to you about the metabolism, biochemistry, and the science. That's at the bench side, the scientific bench side. I want to take you to the bedside. So when a patient walks in my office, what do I do? Well, there's a concept, there's a food prescriptive approach, and we want to integrate that in the clinical setting. So what are the basic concepts? Well, the first concept, we have to understand that there's only one chronic illness. The next concept is that what you remove from your diet is the most important step towards optimal nutrition. And the third concept I want to go across is the concept of many nones and two thieves, the total removal versus moderation. This whole concept of chronic illness, this is a picture of a tree. It's in my book. As though you can't see it too well from the back, you see the trunk of the tree with leaves and branches, and each of these leaves and branches have a diagnosis. You have the hypertension leaf, you have the headache leaf, the allergy leaf, the lupus leaf, et cetera, et cetera. And when you go and see your doctor, we treat these leaves in isolation. You have a headache, I'm going to give you something for your headache. Your blood pressure's a little high, I give you something for that. Your cholesterol's up, I give you something for that, and so on and so forth. So you have enough problems, you walk out with a sack full of medications. Some of my patients tell me they're afraid to complain of anything with some of their doctors. They get so many medications. So in essence, what we're dealing with is isolated manifestation of one disease. And that one disease is poor nutrition. So in concept, what we want to do is address this mechanism, and when we address this mechanism, all of these manifestations go away. The next concept, the removal of foods from your diet. So when I talk to my patients, they come in, and they've already gotten a scouting report on me. You know, my reputation is out in Houston. So my new patients come in and say, Doc, I eat lots of vegetables, because I'm the Dr. Sprouts, right? So I eat lots of vegetables. But I ask them more about what other foods do you eat? When you go out to parties and when you go and have fun, I try to dig into it. So I try to find out what bad things they eat because I want to look for the bad and totally remove the bad. Because what happens is the disease states come about when we put in excess amounts of poor nutrition. These may be dead animal flesh meats. They may cause constipation, may impair kidney and liver function. They may be processed carbohydrates, lots of preservatives, which may also impair liver function or impair kidney function. So when we put in excess amounts of toxic substances in the body, it impairs the body to actually cleanse, heal, and repair itself. And so you result in a small removal of toxins. So the first step in detoxification is to not tox. So we remove every form of poor nutrition from the diet. Not a bite, not a drop, not a crumb is our concept. And when we do that, you X out the bad and you enhance the removal of the bad from the system, and that improves the body's overall well-being and overall health. So that's how you jumpstart the body to overall health. But what about this concept of, well, doctor, can I just eat baked chicken in moderation? How about a piece every other day, once a week, et cetera, et cetera? And I say, well, okay, fine. But let me ask you something. What if you were to open a bank and you hire tellers, 5 nuns and 2 thieves? And after the first 2 weeks, you check all your drawers, and all the drawers come up short. And you scratch your head and say to yourself, well, we just need more integrity among our employees. So you hire an extra 5 nuns. So you got 10 nuns and 2 thieves. So another 2 or 3 weeks go by, your drawers are always still coming up short. You scratch your head, I really need more integrity. Another 5 nuns, 15 nuns, 2 thieves. Another 2 to 3 weeks go by, what do you think is going to happen? The drawers will be short. The concept is that you have to remove the 2 thieves. The bad food, especially when we get to chronic illness, once you've been given your certificate for diabetes, once you've had your card stamp for heart disease, your card stamp for hypertension, you need to totally remove those thieves in order to get the optimal health in terms of reversing your disease. So there's no moderation that should be had. Dr. Esselstyn, in one of his chapters in his book, Moderation Kills. I love that. And it does. And so you got to totally remove those thieves, et cetera. So how do we do this? And we're getting close to the whole concept. What we've developed is a program model, and I'm going to talk to you about a program and concept, and I'm going to delve down into the details of what we do and how we do what we do. So in essence, what we put together is quote-unquote institutions within our practice. There are critical personnel we've defined. There's a facility that we have that has critical things, and there are key programs that we've developed, or I should say are developing, for the implementation of this food prescription approach. The institutions. Now, these are not necessarily well-defined institutions per se, but rather they exist in concept. Within our practice, we have medical and surgical treatment. I have a clinic, an institution. We do medical therapy, we do vital signs, we draw blood, we do echoes, we do a number of things, and I'll show you some diagrams showing that. But we have a wellness nutritional component. On weekends and evenings, we have nutritional boot camp classes. We take patients to supermarkets, and we have food demonstration classes, food preparation classes. We have exercise. I have 2 certified trainers on staff. However, there's data and research, and this is less well-defined, developed, I should say, but we've developing data and research. We're tracking the things that we do, and I'm going to share some of the data with you of some of the patients we follow. And I think this is important for any institution that's following any clinical program. You need to track what you're doing so that you can get feedback on whether or not what you're doing works. And so we're developing this data, and we do plan to do research. We have an affiliation with Texas A&M University, and we're working on getting some of our work published this year. Clinical personnel, this is a busy slide, but I'm just going to go through this fairly quickly. In essence, you have the medical staff. There's a physician, and needs to be board certified, plant-based, and actively practicing the mainstream medicine. The reason is I want this this integration approach integrated into standard medical care. That's our model. So basically, as I said, my day job, I'm in the medical center. I'm seeing patients on a regular basis. Why is that? The majority of people with diabetes and high blood pressure are going to end up in the emergency room or in these standard medical practices. We need to be right there to capture them and pull them into this area of integration of medicine. Many of them don't know about plant-based nutrition, and many of them being told wrong things by the dietitians. Hopefully there are no dietitians in the office, or at least non-plant-based dietitians. But anyway, the dietitians in the hospitals are telling them the wrong things in many cases. And I'll give you some examples of that later. We need administrative staff to help manage the whole program. And we developed mid-level practitioners, nurse practitioners, PAs, and also the technical staff. Part of the technical staff is culinary team. We have a restaurant within our facility, and I have chefs. And we run a restaurant which is open to the general public, because part of this is about food. It is the food. And the food is very, very important. And we have to be right on top of the food. We have to be right on top of the chefs to determine how the food is prepared. And we're, in fact, reinventing food or remodeling the food. You know, our concept of a healthy, delicious meal has been very skewed toward what's unhealthy. And we have to bring it back. So part of this whole concept is developing culinary team as well as other things, research technicians, medical technicians, and the like. So what is a facility? So as I said, we have the Medical Health Wellness Center. This is a picture of our facility. We'd like to have a nice, plush environment. We have a gym inside the facility. We also have a restaurant where it's not only open to the public, but also is open to our wellness clients for food demonstration classes, as well as food preparation and cooking classes. So there's in-office counseling. There's one month educational course. We call it the boot camp. There's a year-long wellness and fitness membership, as well as meal plans that we apply. So when a patient comes in concept, what do we do? So someone walks in my office, they have high blood pressure, and it's not uncommon for us to see patients with a blood pressure of 240 over 140. My staff doesn't even wince when we see that. It's not uncommon for us to see patients coming in fully volume overloaded. We've had a patient walk in our office in ventricular tachycardia. We've had to call the ambulance. And we give them lidocaine, stand there with the defibrillator ready to shock them. I had a patient come in with massive saddle pulmonary embolism. So we see patients at every end of the spectrum in terms of illness, not only in the office, but also in the hospital. And this therapy, nutritional therapy, is applied at every spectrum. If they're in the unit on a ventilator and are being fed with a PEG tube, we apply the same therapy, and I'll talk to you how. So we assess their clinical condition. If it's very critical, we need to optimize the medical and surgical therapies. We may have to add or reduce medication, consider the need for surgeries or procedures, and we attempt to delay any medical or surgical therapies if possible. We initiate the food prescription immediately, okay? And I'll talk to you about how we do that. We start them on the detox regimen as well as a maintenance regimen. We then try to wean them from medical and surgical therapies as soon as we can once the nutritional effects take on effect. And we initiate other lifestyle interventions, including exercise, et cetera. Now, I came in at the tail end of the last discussion. There was some controversy about exercise. I don't want to get into that too much, but my patients and clients often ask me about exercise. So, Doc, what about exercise? When I got into this early on, I'd started talking about nutrition, and they would trick me. I would go on and talk about what they should eat, and then they said, Doctor, what kind of exercise should I do? And then I'd go and talk about exercise. I said, well, walking's good, bicycling's good, swimming's good, et cetera. So then they come back 2 weeks later. Are you following the program? No, I'm still eating a cheeseburger every now and then, but I'm walking an extra block. So the point is, I put these things toward the end because optimal nutrition is very important first and foremost. In fact, it might even be dangerous to eat bad food and run or exercise vigorously, because these things can have an adverse physiological impact, blood pressure, heart rate, and the like. So what I tell my patients, I say, I'll tell you what, let me ask you this. If I put 5 drops of cyanide in your coffee every morning, how far would you have to run it off? They don't have an answer. The point is this. It's the biochemistry of these foods. It's not the calories. It's not the portion sizes. These foods are poisonous not because they are high in calories or high in fat per se. These foods are poisonous because they're poison. It's the adverse biochemistry of these foods that's problematic, and so they need to be removed. So it doesn't matter if you're thin or if you're heavy or anywhere in between. You should eat bad food. And then once you're not eating bad food, then you can exercise. Exercise is very important. So here's a look at our facility. We have nice exam rooms. We want it to be relaxing. We have nice curtains there, echo machines. We do vascular studies. This machine here is ECP's external counter pulsation. let's say you have chest discomfort, you have blocked arteries, and you don't want to have your chest cracked open, we can actually do non-invasive bypass right in our office. We have this machine here, does EKGs. This machine can measure hemodynamics. I can get the similar type hemodynamic measurements that I got when I used to have to stick a needle in your jugular vein, float a catheter in your heart to get measurements. I can now get it non-invasive with this machine here. We do our own blood draws and stress tests, et cetera. So we have a comprehensive medical side because we know all of our patients need to be medically evaluated and assessed, and we do that in the clinic. Once we've done some evaluation, we try to put them in a category 1 through 5. Let's say a young, healthy chap comes in, you don't have any known medical problems, but you're eating bad food, then we put you immediately in the food prescription program. We might do some limited screening and clinical tests, but no therapies. You go to maybe level 0 to 6, maybe not as aggressive. The higher up in the categories, you can see the more acuity the illness is. Patients who are sent to the hospital emergently, maybe having a massive heart attack, et cetera. We stabilize your medical condition, but again, we still apply a food prescription, a more aggressive food level. And I'll talk about the food level system a little bit later. So there's clinical assessments. We place you in categories, and we apply these therapies accordingly. Medical optimization, sometimes you need surgery, you need a defibrillator. Sometimes we need your pills to be increased or decreased. So optimization doesn't necessarily mean adding things. It can mean reducing medications as well, or simplifying your nutritional regimen. Oftentimes, patients will come in my office. It's nothing for me to see them on 20, 30 medications, and supplements included. And one of the first things we do, we'll cut the list in half. We'll always consider the possible need for surgeries and procedures. You know, one of the tricky things about this, practicing as a medical doctor and trying to apply this therapy, my colleagues ask me this and say, well, you know, how can you avoid risk of being sued, okay? And what if a patient comes in and you apply this and you take them off the medication, they get sick? Aren't you afraid of getting sued? Well, there's always a risk of getting sued when you're practicing clinical medicine. That's number one. Number two is that we always consider the so-called standard of care. So I'm giving my patients a spectrum of options. It's just that the difference is, I say, look, here's the standard of care, and here's what the standard is, and here's some other options. And I'm going to go over the risks and benefits of each. And so I'm going to give you a broader scope of things to choose from, and I'm going to help you go through that. And sometimes we may have to do an integrated approach between the two. So it's not a matter of always either or, but you always have to have this lifestyle intervention approach. The problem with our standard Western care is that we only look at this one area, and we don't look at the area of lifestyle modification in a serious and precise way. And that's what this model is trying to help us do. So we also try to attempt to delay medical and surgical therapies as much as possible. So when a patient comes to our office, the nutritional intervention, it can happen in multiple settings. Now, if they're in the office, we may initiate it in the clinical setting. So if they come as a new patient or follow-up patient, I'll do the medical evaluation, do the examination. We may draw blood, do tests, but they'll then see one of my wellness coordinators and get a one-on-one visit and discussion on what to remove from their diet and what to eat. We try to start them on that right away. So they started on, now we raised the bar pretty high. We put them on raw fruits and vegetables. So I kind of jokingly refer to that as grass and water diet. And so now I'm going to visit True North tomorrow. So now I have a place to send them. If they don't behave themselves, I'm going to say, look, if you don't follow the grass and water diet, I'm going to send you up there. They're going to take away the grass. But we raised the bar initially as a detox. They get fast results, and then we relax after a while. It makes it easy, and I'll show you how we do that to some extent. We give them food samples. So after I've sat down in the office and I said no chicken, no fish, no biscuits, no gravy, no steak, no pork, no eggs, no yogurt, no coffee, no this, and we resuscitate them from that. We then have a wellness coordinators take them to the restaurant, and our chefs prepare food samples. So they learn how to eat chocolate brownies, key lime pie, nori wraps, and all of that, but it's prepared in a healthy manner. And so then they say, wow, hey, I think I can do this. If they're in the hospital, it might be a little more challenging. In the hospital, they use what's called the Montgomery diet. That's raw fruits and vegetables only, because I don't trust how the hospital cooked the food. My patients happen to have a difficult time on that, and the hospital is a little bit of a struggle. I recall one situation, I was rounding one morning, and one of my patients was admitted by the house staff, and the house staff typically write for AHA diet. So I go up to the room, and just as I walk in, the guy's delivering the tray, puts it on a table. So I go and uncover one of the smaller parts. I see some sliced onions and sliced tomatoes. Hey, it's pretty good. Uncover the larger, I see a hamburger. Whoa, what is this? So I'm a little bit upset. So the guy's, dialing the dietitian. So, well, this is what they ordered. And he hands me the phone. So I talked to the dietitian. So what is my patient doing with this hamburger? He said, well, she's on the AHA diet. That's a cardiac burger. I said, a cardiac burger? So I'll tell you what, send her a pulmonary cigarette to go with a cardiac burger. The point, the hospital can be a challenge. And so they only go with the raw, strict vegetables. Now, we've recently, as of the last few weeks, have started allowing my patients to get food from a restaurant. We're only 4 miles away, so if they have a family member that can pick it up, we'll let them order. It's on the house while they're in the hospital, just so that it can tolerate natural food. So we're working that aspect out as we speak. How about extra clinical programs? It's one thing to talk to them in the hospital or in the clinical setting. However, we have extra clinical programs. We have a 1-month curriculum. We call it the Nutritional Boot Camp. I'm going to show you some data on that. It's a 1-month, 5-session program. They come on Saturday mornings. My wellness coordinators lead the sessions. There's a 3-hour presentation where it consists of PowerPoint presentation or educational video. There are food demonstrations. We have 2 sessions where we take them to supermarkets after hours during the week. They also have cooking classes as a part of this whole curriculum. There's annual wellness memberships where they start off with a boot camp, and there are monthly meetings and sessions where we track the results and go over their progress over time. We integrate exercise with this wellness membership as well. So there are many programs that we use to integrate both in the clinical setting, juxtaposed to it, or that we run parallel to the clinical setting outside of it. So when we talk to someone, what do we remove from the diet? Well, all forms of animal flesh, fish, chicken, beef, pork, worms, roaches, rats, etc. For those that are desperate, we remove all forms of cooked foods, initially oils, nuts, processed foods, and pasteurized foods. Now, notice I have dead or alive here on animal flesh. I used to say remove all forms of dead animal flesh. One of my colleagues who's a wisecrack said, well, can I eat the animals alive? And I said, yeah, they go in alive, they have to come out alive. So I've revised this and said dead or alive. Now, so what do you consume? What can I eat is the normal response. And the normal food is water, natural plant-based foods, fresh vegetables, seeds, sprouts, sunshine. I put water at the top, because I think water is the most important nutrient. Most of you, especially those eating plant-based, get that question, where you get your protein? Where you get your protein? My response is, shut up. That's the wrong question. I don't say that all the time. And I don't need to go through this. Dr. Campbell handled this very well in his talk last night in terms of how protein is not that important and the wrong type of protein can be detrimental. But just think about it from a common sense standpoint. Okay, let's put all of our biochemistry knowledge aside and all of our medical and clinical knowledge aside and just sort of common knowledge, and we sort of commonly know, the average layperson know that the body is made of mostly what? Water. And it's about roughly 75% water. And if you were stranded on an island and someone said, I'm going to leave you here for about 25 days and I'll be back. Now, you have the option to have a 25-day supply of baked chicken only or a 25-day supply of water. Which would you choose? Water. It's pretty obvious. And so water is our most important nutrient. Now, notice I say most of it should be eaten. Now, that's kind of a strange thing. If you think about it, though, plant-based foods, their composition is mostly what? Water. And so if you're eating a lot of plant-based foods, especially the fresh foods, that's raw, natural foods, then you're going to get a lot of water. My patient said, well, doc, how many glasses of water do I need to drink every day? I said, I'll tell you what, why don't you eat 1.5 watermelons every morning, large size, and you come back and tell me how many glasses of water that you need to drink every day. The answer is that very little. So if you're eating a lot of fresh fruits and vegetables, your amount of thirst will be low. You won't have to drink as much water. And you're probably getting a better form of water that's plant-derived, just as other nutrients that are plant-derived are probably better. But the bottom line is that water, natural plants, and sunshine for vitamin D, fresh air, and the like. So what do? This food prescription, I throw this phrase around a lot. We actually have a food classification system. Now, I'm not going to bore you with all the details, but the gist of it is the following. It's one thing to eat plant-based foods, but we have to consider what's happened to the food before it's gotten to your mouth. So we first of all ask a series of questions, and based on how those questions are answered, we classify the foods at a level 0 to 10. And that simplifies it for our wellness clients and our patients. Now, they don't have to do the classification. We've done it for them. We give them a list of foods and the preparation manners of foods in the classes of 1 to 10. It's in my book and also in our manuals. But these basic questions are, one, what's the fundamental source of origin? Is it a plant? Is it from an animal? Is it an inorganic source, a synthetic source? You know, what conditions did it develop in? You know, if a psychiatrist evaluates a patient, tell me about your childhood. You should ask that about your food. You know, tell me about your childhood. You know, level of processing, chemical characteristics. You know, you get the okra from the garden and eat it, it's healthy. You get the okra from the garden, you batter it and deep fry it, it's probably not as healthy. And so these concepts are taken into consideration when you're considering the classification of the food. So, you know, fried, battered okra may be sitting right next to fried chicken in our food classification system just based on what's been done to it. So we have a scheme here. 0 is the bullseye, all the way to 10. We recommend not going past 6. We have zones, detoxification zones, 0 to 3, 4 to 6, and 7 to 10 is there. And again, our clients know what these zones are because we give them a list of foods that are in these zones. And I'm not going to bore you with the details of that. So how do we implement the programs? Well, there are a lot of tools that we use. We have compliance cards. You know, we don't have drones yet to follow our patients and clients around. We're developing that technology. But in the meantime, we have to use compliance cards. And so they track, especially during our 1-month boot camp class, they track the food levels they've eaten for a certain week. I'm going to show you how we use that. And we have data tracking reports where we track their progress and correlate it with the compliance. And we give them food preparation projects. They're assigned recipes. They have to design recipes applying foods in this. So that gets them hands-on in shopping rounds, as I mentioned earlier, and have food preparation classes, as I mentioned earlier. So how do these tracking reports work? So here's an example of one of our clients in a boot camp. And so they start the boot camp session 1, the first weight is there, and you see them making nice, steady progress over the course of the boot camp with weight. The blood pressure is coming down nicely. These are real numbers, by the way. And so we look at their compliance card, and this is a little bit complex. This is eating at food level 0, 0 to 3, 0 to 4A, 0 to 6, and 0 to 7 plus. We tell them not to go during detox above 0 to 4A. So 29% of the time, this person is 0 week 1, 43% of the time 0 to 3, and 29% of the time they're 0 to 4A. And we follow that throughout the course of the 4 weeks, and we notice that there's no time at the point that this person went above 0 to 4A. So we see that it had steady progress, okay, as I go back. So we go forward. Okay, let's look at example 2. Now this subject had some progress and then went boop. Then down here, the diastolic, had some weight loss and all of a sudden boop. And then we said, what happened? Now they had a total loss, but they lost some of their momentum here. If we go and look at their compliance card, week 1, week 2 they did okay. Oh, look what happened in week 3. They went way off. Okay, a piece of chicken wing got loose and flew into their mouth. And, you know, that happens from time to time. We get that reported, probably 10% of our clients. But they tried to come back week 4 and didn't make it back. But they did have overall success. But we use the compliance card to help correlate what's happening to the success. And it works as an excellent feedback tool. I mean, we, human beings, we like feedback. And so if I know I'm going to be tested on something, I'm going to more likely comply with it. And then if I know if I fall off the wagon, I fail the test, and I see the bad results, I'm going to get back on the wagon as soon as possible. So this, the tracking is in part of the therapy, if you will. This complex, funny-looking slide here shows the course of a year. So we may have somebody, let's say we have a very complex patient, bad hypertension or diabetes, or bad heart failure for that matter. We may have them go through detoxes maybe 4 times a year. So if you look at here, this is level 0 all the way to 10. Now notice the healthy person can eat 0 to 6. 0 to 6 is, you know, your bean soups, cooked foods, and all of that, all the delicious things you're eating here, all the healthy, not any cooked oils. But 0 to 3 or 4A is raw, 4C is lightly steamed. So they can maintain themselves lightly steamed on a regular basis, but 4 times during the year, we may put them through a 1-month detox. And here they may just do a juice feast for 1 month. And so we do this repetitive detoxing to cleanse the system. We found that it has kind of a bolus effect that overall helps them get to an overall better lifestyle. So let me give you a few clinical examples. I'm going to give you the first example is a patient that I saw very early in my practice. And she didn't have the food prescription. 69-year-old lady who was referred to me for dizziness and forgetfulness, and she was diagnosed with a brain tumor. Eventually, when I saw her for dizziness, I felt it was neurological. I sent her to a neurologist. They got an MRI and diagnosed a brain tumor. Now, she had a history of diabetes, chest discomfort, hypertension. She was overweight, had carpal tunnel syndrome. And because of this, plus she was on medication for a long time, high blood pressure. She probably was on maybe 6 or 8 medications at one point, maybe as many as 10. We had to do a pre-op evaluation. We did a stress test, which is abnormal. We catheted her and found that she had a critical stenosis, and she had an angioplasty and stent placed. And so she recovered from that, then underwent surgery. The tumor was successfully removed. So there we were. We successfully battled heart disease and a potentially cancerous tumor. And we were pounding ourselves on the chest. We're the world's largest medical center, and yeah, we bad. But there's more to this story, and we'll talk about that later. Let's go to example 2. Now, this is an example where the food prescription integration was applied. Now, this is a 46-year-old lady. She worked in an oil and gas company. They had a health fair, as these companies typically do. And so, you know, she had some vital signs taken and things, and she knew she was overweight. She was feeling fatigued. So she felt that if I can only lose weight, you know, everything would be better. The sky would be brighter, the sun would be shinier, et cetera. So she went for gastric bypass surgery, but they got an EKG and saw it was abnormal. They said she needed to go get clearance. So she sought us out for clearance. And on history, she had obesity, of course, and was told she was pre-diabetic. We didn't have the data for that. She had some transiently elevated blood pressure. But the thing that worried me most is that she had chest discomfort that woke her from sleep. And something that wakes you from sleep is something that's pretty significant. She had shortness of breath with mild to moderate exertion, and she had a generalized fatigue. And fatigue is a common sign of heart disease in women. So we repeated the EKG. It was abnormal. I did an echocardiogram in the office, and I saw that her heart was beating 20 to 25%. So here's this lady in her prime of her life, working every day, quote unquote normal, having some vague symptoms. However, she was in congestive heart failure. So I talked to her, and in the concept of our approach, assessing her clinically, I said, we need to do a heart cath, okay? So the next step is we took her to the hospital. I put an angiogram, did an angiogram, here's my catheter, and lo and behold, if you can't see that from the back, there's about an 85% narrowing right there. This vessel here is called the left anterior descending. It supplies about 75% of the left ventricle. And this is a very large vessel, so she had quite a bit of compromise. There's some disease in other places I'll point out later. But in essence, she had a pretty significant heart disease. And so this isn't a lesion that you can stent very easy. You try to put a stent right here, you push plaque back into the left main right there, and you can kill her on the table. So you definitely don't want to do that. So after this procedure, we pulled back. I sat down and talked to her and her husband. And again, by reviewing the food prescription approach, we assessed the baseline condition, which we did, and the whole concept is optimizing medical therapy, consider interventional surgical options with her, optimize medications, discuss non-surgical, non-interventional options, and assign a nutritional level. So we do all of these things, and this is the approach that we took with her, and we monitor progress over time. So what did we do after the cardiac catheterization? We told her intervention was a theoretical possible but not realistic. The simple thing to do would be a simple coronary bypass, probably a Lima to the LAD, or she can forego that and do some non-invasive approaches. And she decided to forego bypass. So we started on food level 0 to 3. I put her on a beta blocker, angiotensin receptor blocker, aspirin, Plavix. Started on external counterpulsation. That's treatment that I pointed to you earlier, that can actually non-invasive bypass to treat her chest discomfort. Then this is the detox program. We gave her a list of foods to avoid. Now this is very important for her. Okay? So we applied this, and after about 5.5 months, I took her back to the cath lab, and the coronary artery lesion was open. Now, if you look at the before and after, you see this left main vessel here. See how the size of this left main compared to the catheter? Not too much bigger. So she had pretty significant left main disease compared to this vessel, compared to the catheter size. And then, of course, that stenosis is gone. So, and we did an MRI in addition to the echo before and after. The MRI of the heart showed the heart ejection fraction go from 24% to 50%. So she had eventually regressed her disease in 5.5 months. Also, she had significant left ventricular hypertrophy, a thickening of the heart muscle. That had gone down significantly. I think about 40 grams of heart thickening had regressed. So this is a concept that was applied here. Here's another example. Example 3, the food prescription integration. There's an 83-year-old female, had diabetes, obesity, hypertension, bradycardia, and poor mobility. Bradycardia is a slow heart rate. And so she came to see us one day. She was on a long list of medications. Not too long, maybe about 12 medications. And so, again, we applied the same approach. Her, on clinical assessment, felt she was a diabetic, mildly controlled, mildly elevated blood sugars. Her fatigue, in my opinion, was likely due to some cardiac ischemia, given that she was a diabetic. And her bradycardia was likely due to sinus node dysfunction, which is kind of wearing out of your intrinsic pacemaker. As we get older, you get scarring of your electrical system, and the heart slows down, your pacemaker system slows down. So medical and surgical optimization, what did we do? Well, we did a monitor. We saw episodes of very slow heart rate. I took her to the hospital, did a heart cath, did an electrical study on her heart, and we found that she had diffuse disease, nothing that was amenable to a bypass, not that I was planning on doing that, but I did felt that she needed a pacemaker. We had some definitive findings on the electrical study, so I implanted a dual chamber pacemaker in her. However, she had already been prescribed food level 4A for the first few months. So even while we were applying this approach, she was already on the nutritional detox program. And then after the first few months, she went on levels 0 to 6 chronically after the detox, and then she had intermittent detox periods about twice a year is what we recommend. So after about 3 years, she was 86, 115 pounds lighter, had lots of energy. She was living independently, and she was able to attend her granddaughter's graduation. This was actually last year. Her granddaughter graduated from Spelman College. Last year, you may remember President Obama was speaking at Morehouse, which was right next door. The Surgeon General was speaking at Spelman. And so you can imagine what the streets of Atlanta were like. She had to walk everywhere, and she was able to get around freely, the after parties, the before parties, et cetera. And that's what life is all about free quality of life. And oftentimes, and I gave you this example of someone in their 80s, because oftentimes I'm told, well, you know, they're in their 80s or their 90s, let them eat what they want. Or they come and say, I've been eating this food all my life. And I tell them, look, you've had enough. Now it's time to eat something healthy. But the real point is simply this, that if you were told that you only had 6 months to live, or 3 years to live, or 6 days to live, it's worth it to eat a healthy diet because it's going to give you quality of life. And that's what you want. We're all going to die, and we don't know when our time is up. But what we need to know is that the best time, our best ability, whether we want to communicate with our loved ones, our young ones, tell stories, roll around in the grass, do somersaults, etc., we need to eat the best food to be the best people that we can be. And this is a part of that story there. Now, what about example 1? We were pounding our chest. However, that wasn't the end of the story. After a surgery, she developed meningitis, developed hydrocephalus, which is brain swelling. She needed a brain shunt. That shunt causes bleeding. She went into a coma, started having seizures, had impaired brain function, more seizures. She had some recovery from that, but she had recurrent seizures, subsequently had a fall. She fell, had more intracranial bleeding. That resulted in more prolonged hospitalization. She was placed on a ventilator. I remember in the middle of the night being called to rush to the hospital. She developed swelling around the heart. to stick a needle in the chest, drain blood around the heart. I mean, we worked aggressively on her. Emergency procedure after emergency procedure, myself and my colleagues. She finally died from liver failure 1 year and 10 months after the brain tumor diagnosis. And I really struggled with this case because I looked back and said, you know, she shouldn't have died. She shouldn't have, you know, we had everything in place. We took care of everything. But after I reviewed her clinical history and reviewed the chart, yes, she had liver failure. And the only explanation was exposure to too many medications and the standard American diet. We had actually added medication during the hospital course, which led to her liver demise. And by the way, her liver enzymes throughout most of this hospital course and prior to the hospital course were never elevated. So you can't just strictly rely on liver enzymes, elevated liver enzymes, as a diagnosis of liver failure, because oftentimes your doctor puts you on medication, say, we'll just check your liver enzymes. Your liver enzymes can be normal, but your liver is not necessarily normal. But the most interesting characteristic about this patient was she was my mother. Now, when I was a little kid, she taught me how to tell time, how to read. She used to read my Latin vocabulary to me, et cetera, et cetera. And she would tell me oftentimes, I'm going to be your mother to the day I die. And I never knew how profound that statement was, because on her deathbed, she taught me the most important lesson in medicine that I'll ever learn. And that's the beauty of this story. Mother knows best. However, as a result of that, we're able to apply the nutritional therapy, because that's my motivation to do this. That's my motivation. That's what drives me, gets me up every morning to push and get the next patient better, to get the message out. And every one of us needs to put a face on this condition. Every one. It's not just a matter of statistics. It's not just a matter of data and biochemical formulas, et cetera. This is a matter of life and death. This is a matter of quality of life. We all have a loved one. We have children, grandchildren, nieces, nephews, et cetera. And we're in a healthcare crisis. And we all need to personalize this whole approach. So I want you to always remember, this is all about you and all about the people around you and the people that you love. So let's look at some data. Here's the data from the nutritional intervention. I'm going to go through this fairly quickly, but this is, I told you we had a 4-week program, the nutritional boot camp, and we've had over thousands of patients go through our program. The data I'm showing you, now this data is unpublished. Now I've contracted some biostatisticians to analyze them. Everything I'm showing you shows statistical differences between the first and second point. And 1 and 2 is the separation by 4 weeks. So all of these changes occur in 4 weeks. So what we see typically is roughly a 5-pound weight loss in 4 weeks, significant systolic blood pressure drop in 4 weeks. Notice the blood pressure, and I know you can't see that too well from the back, but the average blood pressure is about 140, and it drops down to 132. That's significant because oftentimes in these drug studies for antihypertensive, they're usually measuring blood pressures in the 150s, 160s to get significant changes. Significant drop in the diastolic blood pressure, significant reduction in pulse rate, significant reduction in inches in the neck, about 2 inches off in the waistline. Again, all this in 4 weeks. Total cholesterol reduction, LDL cholesterol reduction. C-reactive protein goes down. There's about a 34% reduction in C-reactive protein. Now, a couple of points here. Notice the average C-reactive protein is 0.61. I'm giving you that detail because the normal on the lab that we use is less than 0.8. So we're starting off with an average normal, and we're still seeing a 34% reduction in only 4 weeks. A major pharmaceutical company did the similar type of test with one of their statin drugs, and it took them 1 year and 9 months to show a 37% reduction in C-reactive protein, but they had to start with a C-reactive protein level of 4 to get it down by just 37%, and it took 1 year and 9 months. This is the power of what the body can do in 4 weeks only on optimal nutrition. Sedimentation rate go down by 33%. The other point, important point about inflammation, inflammation underscores virtually every chronic illness that we know. So when you're seeing inflammation go down, then you're seeing disease rate going. Your risk of heart disease and diabetes or a heart attack or stroke is going down. Cancer risk is going down. So inflammation is an important player, and that's why we're emphasizing this up front. Blood sugars go down, and the hemoglobin A1C is reduced. Now, you may say, well, the hemoglobin A1C is an average of the blood sugar over 3 months. So why are you seeing a reduction in 1 month? What happens is you have less in the way of blood sugar swings, and the blood sugar swings also influence hemoglobin A1C, and I think that's what we're seeing, a greater stabilization of blood sugar. So, in summary, optimal nutrition should be the foundation of all forms of health and medical intervention. Patients requiring advanced medical, interventional, and surgical treatments benefit from an immediate nutritional intervention. So even if they're in the cath lab and they come out of the cath lab, raw fruits and vegetables only. I've had patients on the ventilator being fed by a PEG tube. I get certain freeze-dried raw vegetables, mix them up with water, and have the nurses put them through the PEG tube and remove all the formulations. And I've gotten into a fight with the dietitians recently. I lost a recent battle, but we've got round 2 later. But these patients are the most motivated. And so it gives you the best opportunity. The patient who comes in sick, who's very ill, that's when you capture them right then and there. They have the greatest motivation, and it gives you the best chance of initiating optimal nutrition lifestyle, and it potentiates success to permeate positive lifestyle changes over the long run. Thank you very much for your attention. Thank you very much. Thank you. Thank you. Thank you. Thank you very much. Thank you. Thank you very much. Thank you very much. I guess we could take questions.
If you are. Sorry, I'm kind of eager. Hi, Dr. Montgomery. Thank you so much for an awesome presentation. It's really cool to see how applicable this is in a clinical setting. And I guess my question was about the reproducibility of this. I guess I'm wondering if your book is kind of the general template to how you can go about implementing this in a clinical setting, because I know it's a lot of work, and I'm just trying to imagine how, you know, medical students and individuals who are creating their own practices can do this successfully.
Yeah, that's a great question, and just to make sure I'm understanding the question is about how reproducible is it? And the answer in concept is that it's very reproducible. What we are actually doing is developing the model. The model's in process, and we have about a 12 to 18 month track to where we could have a certification program in place, and then beyond the certification program, we're going to develop a model that's franchisable. And so whether it's this model or other similar models, the concept and the approach, I think, is very reproducible. And what I tried to demonstrate here is to some extent, some of the global concepts in terms of what you need to put in place to develop this approach and then implement it over the long run.
Okay, thank you. And just one more quick question. I imagine that it was difficult working with the hospital because it already sounded like you had some issues. So I just wanted you to comment on kind of how that went about.
You know, it's the hospital's kind of funny. I think the timing is quite right. And you know, along the lines of that question, you know, I need to take my hats off to my senior colleagues, Dr. McDougall, Dr. Campbell, Dr. Esselstyn, Dr. Ornish, who's not here, because these guys came at a time where this was not as receptive. And we're at a time now, we're at a crossroads, because we're at a point where we're having a hard time affording the sick care. Many of the doctors and surgeons are frustrated with many patients who are very sick and were on many medications, and we're at our wits' end. So we're at a point now that I'm starting to see that an approach like this, just based on its efficacy, is actually becoming more receptive. I've given grand rounds presentation at among cardiothoracic surgeons at the university, at the Texas Women's Hospital, and also Meharry Medical College. And I was surprised in each case how receptive my physician colleagues were. And in fact, when I gave the grand rounds at the Texas Women's Hospital, I was peppered with questions. You know, at the end, a couple of guys followed me to my truck. 2 of the guys were at the restaurant that evening, and 2 had signed up for the boot camp. So it was very well received by the physician staff. The hospital is another issue. I think there's some bureaucratic issues with the hospital. The one example I gave you with the patient I fed through the PEG tube, I started feeding him super green food, dehydrated super green food in the PEG tube. His condition started improving drastically, but the dietitian didn't like it, so she started, you know, nitpicking, if you will, and actually saw that one of the probiotics were dangerous, quote unquote. And so, you know, a series of emails went back and forth, and hospital directors got involved, and they stopped feeding the patient the food and what have you. So I've come across those battles from time to time. For the most part, it's been lukewarm to slightly favorable, and from the standpoint of individual doctors, you know, whom I'm friends and colleagues with, whom I respect, they respect me, they've been quite receptive. So it's been a mixed picture, but I think it's moving more toward toward more favorability down the road. Yes.
Thank you, Dr. Montgomery. This was an amazing presentation. Just one question. I looked at all the levels. If the patient doesn't have celiac disease, why gluten-free?
You know, that's a good question. I was having lunch with Dr. Craig McDougall yesterday, and we were talking about that. There's some talk about gluten-free and et cetera. There's some people have problems with gluten-free. You know, we're all familiar with the concept of celiac sprue, and that's one well-defined and well-known clinical syndrome where people have gluten intolerance. However, I think there are a lot of people have subclinical problems with certain foods, and we can't have there's not an overt clinical syndrome or problem that we can identify. So what I do up front is I remove everything that I think could possibly be a problem, because I want the best chance of the best success up front. If somebody's coming in and they're on their last breath, et cetera, I'm going to give them my best shot up front. You know, you're a sniper, you got one bullet, you got to take them out. And so I want to give them my absolute best up front. Later on, we back in and we can sort of negotiate various things. The other aspect of doing your best up front, if you get success there, then when you start to add various other things in, and then they start to have a regression, then you can say, well, you know what? We were at a point where we were doing very well, and we know that that works. So let's look at some of the things we added back and start to remove them. So gluten becomes one of those things that we just may add back or just keep out at the beginning just to give ourselves the best chance.
Hi, I've got a somewhat similar question. I was also looking at your different levels and noticed that you have a lot of things that are raw or slightly boiled for not very long periods of time. But there are some doctors here who would say a baked potato might be a great staple. And I was wondering, that wasn't really on your list, and your opinion thereof.
So you trying to start fights or what? That's a great question. You know, and I was anticipating that question. And it's a great question. Here's the concept, and I'm going to reflect on. I remember an interview with Dr. Esselstyn on, I think it was CNN. He and Ornish were speaking, and I think the interviewer raised the issue of fish oil. Esselstyn's no oil, and Ornish fish oil, and so he was trying to raise a controversy. And I like Dr. S's response. I'm not going to argue over a few drops of oil. The point is simply this. Cooked foods are not the absolute bad foods. I think more work needs to be done on this. And here's my thinking. I think the best food is going to be the least processed food. Okay? So I try to stay away from labels like raw, because they're actually raw foods, quote unquote, technically raw foods, or foods that are considered in the raw food, you know, era, that are not very healthy also, because a lot of them are dehydrated. So the minimally processed foods are going to be the best foods. And so that's why we start with foods that have not been heated or processed in any other aggressive way, and we say those are the healthiest. Then we go to the other end of the spectrum, and we say, okay, what are the foods that are processed the worst? Fried, battered, you know, over the microwave, grilled for 5 hours with oil, et cetera, et cetera. So we all agree that from this spectrum to this spectrum, you're probably better off here than here. So somewhere in the middle is where the differentiation occurs. And what we've seen in our experience is that we start them off raw, we can relax it to minimally processed or cooked foods, and then they do quite well. But I think more work needs to be done. In fact, I have a question for Dr. Campbell later on regarding cooked foods, but I'm not going to get into that now. But next question.
Dr. Montgomery, I'm Tom Gehring. I've been a trial lawyer for 35 years.
Uh-oh.
Yeah, defending doctors like you.
Okay, good.
It was
Thanks.
very easy. It really was actually quite easy. It strikes me to narrow what you've already said several times. I feel like saying, as a trial lawyer, you might be the one, in the sense that I've dealt for 35 years now with the standard of care in the community, defending doctors like you. You've been the first to lead me to believe that it's coming. The standard of care is coming, being what you're doing. So I wanted to have the courage to ask you, within 3 or 4 or 5 years, isn't the way you're doing it, one, going to be the standard of care? And in the middle of answering that, if you could, what do your informed consents look like? And for your audience here, we lawyers are constantly dealing with how a doctor like Dr. Montgomery, has the patient sign informed consents so that they're fully informed instead of having these terrible surgeries. You're eating right.
That's right.
So can I ask you about that? If you could project when you're going to me, I can tell you 35 years, you are the upcoming standard of care. And how do you handle informed consents? And I hope that's not a boring question for your wonderful audience.
No, it's a great question, and I hope your projections are correct. I don't have an answer as to when this will take on. What I'm seeing what appears to be a transition, and I hope it's going to take hold in the not too distant future. There's a lot of work for many of us to do. Regarding informed consent, our approach is quite simple. What I do is I offer my patients the standard, the whole spectrum of the standard of care, and then I extend that spectrum to a healthy lifestyle approach. If you look at part of the spectrum, the recent ACC guidelines that talk about patients with heart disease and diabetes, et cetera, and they say, well, give them all a statin. If you have diabetes, statin. High cholesterol, statin. 7.5% chance of heart attack in the next 10 years, statin. Known heart disease, statin. You don't have to check the levels anymore, just give them a statin. So what I do is offer them a statin. And if they refuse the statin, then I document in the chart, Mrs. So-and-so, Mr. So-and-so declines taking a statin. Now, what I say in the office and how I say it, may be a little bit more coercive. Now, do you want to take this statin drug that's going to kill your liver and cause diabetes, or do you want to eat healthy and be, natural? So the point is that we offer the spectrum, and we let them choose. Just like the patient I gave you an example, yes, she had the option of open bypass, and she was brave enough to say, look, I don't want that now, I want to try this. And then we worked with her, as opposed to had she been in another physician's care and refused surgery, she'd have gotten screamed at and just sent out of the hospital, okay? But instead, what we did is say, okay, great. We will work with you on this approach, and not only will we work with you, we're going to give you the precise steps and tools and instrumentation to help you be successful there. And that's what we do that's different. So from a medical legal standpoint, you come and review my chart, and you say she refused surgery. Well, she has a right to refuse surgery. And so if someone wants to sue me over that, go ahead. I can't force her to have surgery
Let me opine
or
on
take a
that.
statin.
I think you got it. I think you did it. Because with an informed consent like that, frankly, to be blunt and not to brag, I've never lost a case involving a doctor like you. But wow, with informed consents like that, that's it. It's done.
Yeah.
You're there.
Yeah. Thank you very much.
So-
Thanks for the question.
My question is similar to the man that was in front of the trial lawyer. Because I noticed on the levels, the food levels, the lack of starch. What appeared to me to be a lack of starch, and it being a main component of great health for the human body. I was wondering, with the raw food, is there a way to get some starches, some good starches in there? And are you familiar with Walter Kempner and the rice diet, who pioneered clinical application of eating healthfully to cure disease?
Yeah,
And
and
would you consider getting some cooked brown rice and some sweet potatoes and potatoes in some of those early levels? And would that accomplish the detoxification that you're looking for?
Yeah, the question is, you can have starches in them. We actually have recipes that have, believe it or not, yams that are raw and shredded. I mean, our chefs, our restaurant is not just a typical restaurant where you just, have a menu and serve it up. It's actually a food laboratory. And so questions like the questions you ask are very good questions, because, the answers are not very clear, in my opinion. And I think, yes, what cooked foods are ideal and how should you cook them. The reason we limit cooked foods, there's several reasons. One, you know, if you tell someone to cook your foods down in the South, you know, we're close to Louisiana, we're southeast Texas. And so cooked greens is 4 hours on the stove with fat backs and turkey necks in it. And so when you say cook, you need to define precisely how you cook it. If you look at our food levels, there's some cooking of the foods. Level 4C is lightly steamed, but we are very precise in how you cook the foods. That's one. Two, during the session 5 of our boot camp, we actually have cooked foods that we show them how to prepare. And one of those is mashed potatoes. In fact, I have a wicked mashed potato. Maybe next year I can come back as a chef and do my mashed potato demonstration for some of you guys. But what I do, I boil the potatoes in water for about 20 minutes, and we mash them. I just use hot water, and we have herb seasonings and the like. And those potatoes taste as creamy as you've ever tasted, and they're very delicious. So we do allow starch foods. It's just early on when we're detoxing, we put people on a very precise diet. Having them on raw foods keeps them away from cooking and microwaving things, because when you're instructing clients, patients, and people in general how to do things, you need to create a barrier. Okay, and so 0, you say 0, they mean 0.5. If you say 0.5, they go 20. And so you've got to say 0 so you keep them at 0.5. And we say raw fruits and vegetables only, and that data I showed you, I guarantee you there's some cooked foods in that data. But we have to say all raw because we know that some people are going to skimp on it. But we try to be precise and keep some barriers. It's not a starch-free regimen, and it's not a pure raw food regimen per se. We use a spectrum, and we move people in and out of that, across that spectrum based on their health condition and response to the approach.
Dr. Montgomery, you have no fear. And if you would agree with me, we have the best audience that you could possibly assemble. Thank you.
Wonderful.
Let's have dinner.
Thank you very much.